which is being brought to you by the members of the AO North America Hand Education Committee in our current series of complications in upper limb surgery. And tonight's session is dedicated to complications after a failure of nerve decompression. Now, all of us deal with nerve decompressions, all of us deal with failures, and in various scenarios, and it is only important and critical, I would say, that we discuss these in an open fashion, and we've got a spectacular faculty, which will be introduced to you by an even more spectacular moderator, my old friend, Jeff Lawton. Jeff, all yours.
Thanks, Chai. So we really do have a very esteemed cast. So thanks, Chai and the Hand Education Committee. I'm the moderator, Jeff Lawton from Michigan. Tonight I'll be joined by Bauback Safa from the Bunkie Clinic, Jonathan Isaacs from VCU, Virginia Commonwealth University, and my friend Phil Blazer from across town from Chai at Brigham and Women's. These are all of our relative conflicts, and they've all been addressed. AO has no financial relationship, and as you know, AO is an educational group that puts on a wonderful series that Chai is chairing, and again, it's for educational resources. There will be available CME credit. This will be after the conclusion of this series, which is in mid-June, for Category 1 credits for CME. AO North America, as you know, has validated the content of this, does not endorse or promote any specific products, and it's for education purposes. A little bit on Zoom etiquette. All of your microphones have been muted, but we do invite your questions. Please use the Q&A, and that's how you will be able to send questions. Some of them will be answered directly to you, and some, depending on time availability, we'll ask the representative speakers live, and then we will get those questions answered. Again, there's a series of learner objectives that we have for every talk. We want to identify common complications. Again, there's a whole series on upper limb surgery complications in terms of fracture tendon, and this is nerve repair and reconstruction. We want to understand the various things and develop an algorithmic approach. So again, this is part of a series. After tonight, there will be a talk on complications of forearm injury, elbow after soft tissue surgery gone awry, and then complications after elbow fracture fixation in the weeks to come, as you see here. These are some of our upcoming offerings for those of you interested. This course in June in Tampa that Chai and Marco chair, I believe it's sold out or close to sold out. And then Jay Bridgman and I are sharing a course in October in Tampa. Again, this is part of an ongoing internet webinar series. In addition to that, we have some freestanding webinars by Jeff Greenberg, Hand Society President, on DRUJ instability, management of bone defects by Peter Ree, and then myself in December on malunions and non-unions of the hand. This will be uploaded to YouTube TV on the AO Hand North America channel. And also, again, there's other avenues in terms of Apple, Spotify, Amazon, and Google in terms of ability to access this. So just an overview of the agenda for tonight. I'm going to give a talk on persistent symptoms after carpal tunnel release, or the dreaded failed carpal tunnel release. Bauback's going to give a talk on iatrogenic injury of the median nerve, Jonathan on failed cubital tunnel surgery, and Phil Blazer is going to present a talk on neurologic symptoms associated with fractures of the distal radius, and then depending on our time availability, maybe pose some questions to the panel. This is a hot topic, and Jonathan participated in this from the Hand Society with Amy Moore. Again, lots of different societies have lots of different great educational material out there, and AO is proud to be part of that. So I'm going to go ahead and get started, and our first talk is going to be on failed carpal tunnel release. Our objectives are to help you develop a method to critically evaluate failures of carpal tunnel release, both yours and from others that you may see as second opinions. Try to develop and employ an algorithm to determine treatments, and then gain some knowledge of some specific surgical treatments. So let's take a look at the scope of the problem. So typical hand surgeon may do 2 to 3 carpal tunnel releases a week as part of their general practice. In a 50-week year, that's about 100 carpal tunnel releases. The literature quotes a number anywhere from 5 to I've seen as much as 26%. But even if we take a fairly conservative 5% failure rate, that means in a typical year, there's about 5 patients of yours that aren't doing as well as you'd like after carpal tunnel release. Depending on your practice, you may see 2 or 3 a year as second opinions. If you've been practicing 20 to 25 years, that means 150 or more patients with failed carpal tunnel. And quite honestly, as hand surgeons, carpal tunnel is really what we do best. I mean, that's probably our best success rate. So over time, you will see these patients, they will see you. So we do want to define our terms. So when we talk about the failed carpal tunnel release, there's failure, meaning the person has absolutely no relief of their symptoms. There's a partial failure, meaning they get some improvement, but they don't get all the way better. And having an algorithm to evaluate those persistent symptoms. They may have had numbness and now they're hypersensitive. And then there's the recurrence, and we can talk about whether or not that really exists. So again, when you're assessing these patients, they're going to come in and sort of dump their bundle upon you. I had a carpal tunnel and I'm no better. In attendance with them is their distraught spouse, perhaps a workman's comp nurse, and then a stack of papers that, quote unquote, you need to fill out as you're meeting them for the first time. And it's real important to sort of take a step back and again, develop a systematic way to assess these. You want to talk about their symptoms before their surgery, their current symptoms, whether that changed at all, and then look at their incision. So this is a typical patient, and there you see the incision there. And there in your mind's eye, you say, well, here's where I would make my incision, and really ask yourself, does it look like someone could do a carpal tunnel release through their incision? And then we'll talk about the special case for a failed endoscopic carpal tunnel release. Again, as part of your assessment, if they had an EMG pre-op, it's nice to have access to that. Perhaps if they're far enough out from their failed surgery, did they get a repeat EMG? Be able to compare those. Is it improved? Is it the same? Or is it worse? One of the things that's sort of newer on the horizon is the role for ultrasound pre-op, and how do we incorporate this in terms of now, if we don't have an EMG pre-op but an ultrasound pre-op, do we have enough experience to compare a pre-op and a post-op ultrasound in the setting of a failed carpal tunnel release? There was an interesting paper sort of along this line, looking at 35 ultrasounds after 35 failed carpal tunnel releases. They found persistent median nerve compression in 30 out of the 35. This is in the European Journal of Hand Surgery. In 20 of those patients, the compression came from residual transverse carpal ligament. In 4 more, perineural fibrosis, and 5 of these had both of them as causes. 1 had tenosynovitis. 4 patients of the 35 actually had evidence of median nerve injury. 1 of the 35, no abnormalities were found. But overall, they found that the surgical findings at the time of revision carpal tunnel release were actually very compatible with the ultrasound findings. Interestingly, they did miss a giant cell tumor, which was found at surgery but missed on ultrasound, which I found interesting. But overall, they found a good correlation between ultrasound and surgical findings at revision surgery. So let's look at a typical patient. This is a patient of mine, 59-year-old, who underwent a carpal tunnel release pre-op. He had electrodiagnostically severe carpal tunnel. At 2-week follow-up, he notes his numbness and tingling was gone. However, what he does note is what he calls zings of sensation into his fingers with heavy hand use. And he's a pretty active guy, so he does tend to use his hands. We, asked him to sort of calm things down and wanted to see if it was going to settle down. Unfortunately, after a few months, no improvement, still has relief of his numbness and tingling, but still has these zings with heavy use of his hand. So we repeat electrodiagnostic studies. Pre-op, his median motor latency was 6.0. He had non-recordable sensory amplitudes and needle changes throughout his thenar musculature. Post-op, it's worse. So his median motor latency is now 8.6. Again, still with non-recordable sensory amplitudes and needle changes. So he has since also had sequential bilateral total knees. So he's been using his upper extremities to help with weight bearing. And now, again, at 3 months or so, he says the numbness has returned. So while he did have some improvement, his numbness was gone, and now it's back. So how do we approach this? Well, a series by Susan McKinnon and her group looked at their experience with revision carpal tunnel in 97 extremities and 87 patients. And they broke this down, as is commonly done, into persistent carpal tunnel, recurrent carpal tunnel, and new carpal tunnel symptoms. And you see the numbers there. Their recurrent group, they found more diabetes and a longer interval from the primary carpal tunnel, and they were found to be less likely to present with pain. What they found is incomplete release of the flexor retinaculum, and scarring was a common intraoperative finding. In terms of the new group, meaning new symptoms, nerve injury was more common in that group. And again, they thought that while carpal tunnel release is most often successful, not always, but these patients did improve with revision carpal tunnel, and they encouraged this methodologic approach to diagnosis and surgical principles, and then we'll go over. So then that brings up the question of, is there such a thing as recurrence? And most people do think so. Most have seen it. This is a group of actually neurosurgeons from Germany, and their article interestingly contended that it doesn't exist. They reported on their 11-year experience with 156 carpal tunnels, so not a tremendous volume of carpal tunnels. 128 of those were done from their department, and in those, 2/3 were completely relieved of symptoms, and 1/3 had some mild persistent numbness, but none were found to have a recurrence. Now, you may argue that they didn't wait long enough to get the recurrence, but 28 were operated on an outside hospital for recurrent carpal tunnel, and their findings in all of those was an incomplete division of the transverse carpal ligament. So their contention was that recurrent carpal tunnel doesn't exist, and it was most likely incomplete release, although many others do certainly report on recurrent carpal tunnel. So this is a review in the Journal of the American Academy of Orthopaedic Surgery by Fraser Leversledge. And persistent carpal tunnel was the most common. And a simple revision carpal tunnel release was often all that was required. And this is from their article. And here you see the persistent transverse carpal ligament on the left, and on the right, it's release. And then the person had relief of their symptoms. Again, they did find recurrence, and most series quote a number in the 12 to 15% range. Again, but all series, all comers, recurrence may be as high as 57%. And again, carpal tunnel release, perhaps doing something to optimize the environment, and we can talk about different options for that later. And finally, the new symptoms, and these were associated with an iatrogenic complication, meaning nerve injury, as you see here from their article. So here's a patient of mine that I saw. This is a 33-year-old mechanic who had a carpal tunnel release elsewhere, and he came to see me at 2 weeks for a second opinion. What he notes in asking him is prior to that carpal tunnel release, he had occasional numbness and tingling, and it didn't get better with splinting. Unfortunately, following his carpal tunnel release, he had persistent numbness and tingling in the thumb, index, long, and what he demonstrates is the radial half of his ring finger. Very weak use of his thumb. His small finger remained normal sensation, and he points out that he did not have that diffuse numbness, tingling, or pain prior to the operation. There was a definite difference following his operation 2 weeks ago. So here you see sort of a typical mechanic's hand, and here you see his sort of mini open carpal tunnel release, reasonable incision. At exploration, unfortunately, what you see is almost a complete division, maybe just a few fascicles of his median nerve, unfortunately, and there's his motor branch, again, divided there. So sural nerve cables, and then a conduit for his median nerve, and then LABC to his motor branch to reconstruct him. And then at 7 months, which was his last follow-up with me, he got back 4- out of 5 pulmonary abduction and a Tunnels 8 to 9 centimeters from his laceration. So he was doing well enough that he stopped showing up for follow-up. Again, Susan McKinnon in their series noted a small but important subset of failure of initial carpal tunnel release. And again, they organize these into persistent, recurrent, and new symptoms. Emphasize a thorough clinical exam, supplemented with electrodiagnostic studies. Again, we can talk to our panelists and see where the role for ultrasound may be. And we'll go through their stepwise surgical management of revision carpal tunnel surgery, including a proximal exposure of the nerve. You'll see their incision is fairly ulnar, really over Guillaume's canal. That involves decompression of the ulnar nerve at the wrist as well, re-release of the transverse retinaculum, evaluation for nerve injury, treatment of secondary sites of compression, and then potential ancillary procedures. So again, persistent symptoms, recurrent symptoms, and new symptoms is sort of the organizing theme. So persistent was associated with an incomplete release commonly, but perhaps wrong diagnosis or a secondary site of compression, such as more proximal compression from a ligament of Struthers, Lacertus fibrosis, the fibrous arch of the FDS, pronator teres, or a cervical source. Scar formation, as you see here, can be associated with future symptoms, tethering of the nerve, as you see here, from underneath the reformed transverse carpal ligament or the pseudo transverse carpal ligament, hematoma or tenosynovitis, or again, perhaps secondary sites of compression. And then finally, iatrogenic injury or new symptoms. Proximally, it comes from the, as I like to call it, the blind orthopedic slide, where you percutaneously slide down the antebrachial fascia. I like to do that under direct visualization. And then distally, the common digital nerve to the middle ring finger. So this is McKinnon's approach. Again, you can see palmaris longus here. So this is a pretty ulnar incision that you see really over Guillaume's canal. They explore and decompress the median nerve from a proximal to distal direction, as well as the ulnar nerve in Guillaume's canal. Re-release the transverse carpal ligament, as you see here, and then an epineurial release, either longitudinal or transverse, depending on the pattern, and then evaluation for nerve injury. If there's secondary sites of compression, those are decompressed, and then her go-to for an ancillary procedure is an implant such as this. I do want to bring up this other concept in what we sort of term an environmental improvement. So this is by the Indiana group, the pedicled hypothenar fat flap. So as you see in recurrent carpal tunnel, you can get median nerve adherence to the reformed transverse carpal ligament. And this is based on taking this nice, healthy dollop of fat in the hypothenar eminence and bringing it over there. This is a adaptation of Mathulin's original technique. Differences, Mathulin divided the artery, as you see here, and brought the pedicle with the flap, whereas the Indiana group leaves it in situ and just mobilizes that flap. And this is what I've come to do. So this is from their article, and you can see here's the ulnar artery, and here's segmental perforators to that pedicled hypothenar fat flap. So this is a cadaveric dissection, as you see here. This is sort of a typical mini open carpal tunnel release, and the dotted incision would be my incision for a hypothenar fat flap. So it starts with an incision just through the skin, as you see here. And then you're going towards the hypothenar eminence and basically raising a full thickness skin graft over the hypothenar aspect to leave that pedicled hypothenar fat flap, as you see here. So you're in this plane superficial to that flap. And then you go deep to it, as I'll show you in a minute, and mobilize it. And this is a typical fat flap that you get. Again, you're mobilizing it from a radial to ulnar direction, as well as excising that reconstituted ulnar flap of the transverse carpal ligament, as you see here. Again, the median nerve is here, and this is where our fat is going to overlie. Then careful retraction of the median nerve and the carpal tunnel contents, including the flexor tendon, to get down to the floor of the carpal tunnel. And again, there's our pedicled fat flap that we're going to mobilize over there. I'll actually set two sutures, one distal and one proximal, before tying either one of them. It makes it easier if you can get that clear space to be able to set your sutures exactly where you want them before you go ahead and tie the first one. And then that allows you to bring that pedicled fat flap down and cover your median nerve, as you see here in the cartoon, and as you see here in the cadaver. So, is this really necessary? Well, a group did a meta-analysis of 20 studies looking at revision carpal tunnel release, and they looked at whether a simple open release was done, a release with flap coverage, or a release with implant coverage. And according to their meta-analysis, there was actually no difference. They found no added value for doing what I just described to you, which is what I've done for 20 plus years. And they said that simple carpal tunnel release without that additional coverage was all that was necessary. However, they do sort of admit that they included a variety of studies, including low quality studies that had a moderate risk of bias and did not actually differentiate between persistent and recurrent carpal tunnel. So it's a little bit of a mixed bag. So what did I do for this patient, again, who had worsening findings and worsening electrodiagnostic studies after his carpal tunnel release? I did a revision carpal tunnel release with pedicled hypothenar fat flap, again, at about 5.5 months by the time we operated on him. So here you see sort of the typical incision. Here you see the mobilized fat flap. And here you see what we're going to cover the nerve with. And it is a fairly robust and healthy piece of hypothenar fat that you can see us tucking over the nerve in the picture to the right. And at 2.5 months, his numbness and tingling are gone, no residual symptoms. And he tested it out by going up to northern Michigan snowmobiling for an 8-hour run and had good results. So he was pleased with it. So the take-home message, we should be taking an algorithmic approach when we see a failed carpal tunnel, either ours or from someone else. Really determine if the patient will benefit from another surgery. Certainly if they have recurrence, most would agree that a simple redo carpal tunnel release is sufficient. However, in the revision setting, perhaps an extended carpal tunnel release and some form of an environmental improvement. And if we have enough time, I'll be interested to get our panelists' impression. And my slides will be available and that'll have all the references. So thank you. I'm going to stop sharing. And then I'm going to introduce Bauback Safa from the Bunkie Clinic. And Bauback's going to talk on iatrogenic injury to the median nerve. So thanks, Bauback.
Thank you so much, Jeff. I'm going to go full screen. Let me know if you can see my full screen now. Yep, great, perfect. Great. Well, thanks, Jeff. Thanks, Chai, for inviting me to be part of this panel. So my task tonight, as you've heard, is to discuss iatrogenic injuries to the median nerve, obviously in the setting of nerve compression release, so specifically carpal tunnel release. So I'm not going to be talking about other operations that can result in median nerve injuries. I'm not quite sure why my disclosure didn't show up in the initial slide, but this is a relevant disclosure. Incision, I do receive research support from them, and I am also a speaker. So with regards to iatrogenic median nerve injuries, this is a known complication. We know that this can happen. We've all pretty much seen it. And it can be kind of anywhere along the median nerve from distally where the digital common digitals were taken off to the median nerve proper itself, if there's a transection of the whole thing, or if someone for some reason chooses to do an internal neurolysis, this can happen. Could be the motor branch, could be a palmar-cutaneous branch more proximally. So kind of the nerve can be injured anywhere along its path. And I'll show a few examples of this thing. Now, in my experience, kind of as a referral center, most of the injuries we've seen have been during endoscopic carpal tunnel release, and usually by folks who are not experienced. So these are oftentimes actually not trained hand surgeons, maybe general orthopedic surgeons, general plastic surgeons who may not be doing as much. And I think one of the key parts of the technique is just to make sure you really kind of scrape down any of the synovium to really clear the view. So when you enter with your scope, you actually have a really nice view of the ligaments from below. So you can really tell if the nerve potentially is sneaking its way in. And I think, usually when the nerve is injured, it's kind of during this section where you're kind of pulling back. So I usually do a dry run. I pull the scope with the blade back without the blade engaged, make sure that everything's clear before I do a full release. So I think some of the common problems that can arise, and I'll show you a couple of examples of when this happened, is potentially from inadequate scraping with the synovial elevator to just not really get good visualization, maybe not doing a dry run. And obviously, if there's any issues, if there's any concern, and let's say the nerve keeps flipping over or something, just convert to open. I don't think anyone's going to blame me for that. Now, from an open carpal tunnel standpoint, Jeff already showed this very well. Obviously, the advantage of this, even if you use a mini approach, is that you go in top down, so you can usually see these branches. So in my experience, the incidence of injuries with the open carpal tunnel does tend to be less, at least the patients who are referred to me. And even through a very minimal incision, you can actually release the entire ligament. You can feel it distally with your pinky, and proximally you can release a fair bit under direct visualization. And you want to kind of think ulnar a bit when you're releasing the antebacular fascia proximally, so you don't accidentally get the palmar-cutaneous branch. So let's talk about these hydrogenic injuries and go through a few cases to kind of show the management of them and some of the pearls and pitfalls. So this is a case from probably about a decade ago, or maybe a bit more actually. And as a woman who at the time was 65, she had undergone an endoscopic carpal tunnel release and had immediate numbness in the common digital nerve distribution in the third web space. And actually, Dr. Lawton mentioned this as one of the potential complications. This eventually progressed to severe palm pain, so much so that it was actually very difficult for her to function. And so basically, this is her now. You can see the incision is actually fairly healed. It's fairly well healed. It's hard to tell even where the incision was. So we opened her up, fairly extensive approach, identified the neuroma, excised this. She was very, very hesitant because of her existing nerve pain for any kind of autografting. And so we basically, this was fairly early in our experience with allografts, and we took an allograft that we had, and you can see that it's actually quite a bit, unfortunately, a bit smaller than the common digital nerve, but it actually did a fairly decent job. We bridged this, and from a functional standpoint, she did pretty well. About a year later, she has 10 millimeter static 2-point discrimination. This is not normal, but obviously it's still good regeneration. And the main thing with her was that her pain was fairly well resolved, and she had full range of motion at that time, was using her hand fairly normally. Now, I want to show kind of another case that's a little bit more extreme. This is a similar story, 26-year-old guy who 2 years prior to presentation had an endoscopic carpal tunnel release. And again, he had immediate postoperative numbness in the distribution of two common digital nerves now, second and third web spaces. Now, whenever you have immediate numbness post-op, that's not normal. So once your local anesthetic wears off, you should be concerned, at least have the high index of suspicion that something may have happened. So sitting on this for 6 months or a year is not the right choice, or not the right thing to do. This surgeon did actually refer this patient out, and by 6 months post-op, he was explored by another hand surgeon. The op note said there was a lot of scar tissue, and he was having difficulty identifying what's normal, what wasn't, and that, quote, nothing more could be done. So another 6 months went by, and eventually he presented to our clinic, and his main complaint was not of numbness, it was actually of excruciating pain over the distal wrist crease. He actually had a palpable mass there. Fortunately for him, his thenar muscles were working, and the sensations to his thumb and radial index were intact. And so here he is, and actually you can see kind of this lump here, and this was where he was incredibly tender. And so we opened this up. We obviously had talked to him ahead of time about the potential that we may not be able to tease away the normal fascicles that are working from the neuroma, and kind of what we would do in those settings. What we found was a very large neuroma in continuity. And fortunately, we were able to, with the microscope, do an internal neurolysis. This is an indication for that, not a regular carpal tunnel release, but if you're doing a neuroma in continuity where part of the nerve is working, or a nerve with an internal pathology like a tumor, obviously those are indications for internal neurolysis. So we were able to excise the neuroma in this case and preserve the intact fascicles. We identified the motor branch. We have the sensory nerves to the thumb and the radial index. And we had a 3 centimeter gap in the common digital to the second web space. And interestingly enough, by the time we trimmed this back to a supple nerve, we had an 8 centimeter gap in the nerve to the third web space. And this may seem to be a very, very long defect for carpal tunnel release, but if you deploy the blade here and you pull back, oftentimes you have more of a longitudinal cut or injury to the nerve as opposed to a transverse transection of the nerve. So in this case, what we chose to do was to actually perform 2 shorter grafts by just crossing these guys over. So we did 2 5 centimeter grafts from the proximal second to the distal third, and from distal second to the proximal third. And so what we did here is basically roughly about 14 months or so out. First of all, his pain was immediately resolved because obviously the offending agent was resected. And his sensation actually in this case was good. He had pretty decent light touch, didn't get any 2-point over the radial middle finger, but by this time it was about 3.5 years post-injury. But his pain was resolved, and he did have good light touch, so fairly good function from this. Unfortunately, again, his motor branch was still intact, so from a functional standpoint, he's still doing very, very well. The next case that I want to show you is actually a little bit more interesting. This is a more recent case, maybe from about 6-7 months ago. This is a 42-year-old police officer, had bilateral carpal tunnel syndrome. The left was released in August of 2020. This was done by a sports guy, so not a hand surgeon. And then a month later, he did the right endoscopic carpal tunnel release. So what basically happened after this was she ended up immediately having paresthesias, or basically complete numbness actually in the distribution of the median nerve. She had a Tenel sign of the wrist, but fortunately actually her thumb abduction and opposition was actually working pretty well. So a few months go by and he gets, eventually she has a nerve conduction studies done, an EMG, which shows severe right carpal tunnel syndrome. And again, no sensory response whatsoever, but there's no denervation in the APB, and the motor remained normal. So the thought here was, could this be a partial injury? What's going on? So we basically considered her for a lot of things. And you can see the incision is fairly distal. It's right at the wrist crease. I like to go a little bit more proximal. I think it's easier to get under the antebrachial fascia and really have a nice path, just personal preference. So obviously we're going to do this as an open approach. We open this up, and interestingly enough, the ligaments appear to be entirely intact. I mean, we've all done redo carpal tunnels where it seems to be like it's intact, but it's just really scar tissue. But the ligament itself seemed to actually not have been released. That could be dense scarring, but that was kind of my impression. What was more interesting is that we explored the carpal tunnel and we actually couldn't find the median nerve. So we're looking at this thing and I'm looking at all the tendons and I'm like, okay, where is the nerve? I'm looking underneath the ligament, see if it's stuck underneath. Couldn't really see it. And then all of a sudden, we have loop vision. So I kind of looked around a bit, and before we extended our incision, I said, what's this guy here? And so this here is the median nerve. It had been transected within the carpal tunnel, and then it had been essentially pulled out, yanked out of the incision in the antebrachial fascia right up here. So these are the fascicles you can see here. Here's a cut end right there at the wrist crease. So somehow the blade obviously engaged the median nerve within the carpal tunnel and just pulled out the nerve and laid it in a subcutaneous position above the antebrachial fascia. So this explained everything except for the fact that she had thumb opposition. So clearly she seemed to have some crossover from the ulnar nerve. And so obviously now we're going to extend our incision a fair bit more. You can see the arch distally. And then we identified basically the proximal nerve. Obviously, we've got to resect this back to a nice healthy level. 3 distal targets here. Put some nerve grafts in. You can use whatever nerve graft is your preference. This is a bit controversial. However, I kind of felt that With the amount of scarring she had distally within the carpal tunnel, I ended up doing a little bit more of an aggressive approach to what Dr. Lawton showed. This is a distally based adipofascial radial forearm flap. This is based on a perforator, not so you leave the radial artery intact. And we just kind of cushioned and wrapped the nerve grafts with this for an additional vascularized layer. The vascular bed in the carpal tunnel itself may not be the best, and actually Dr. Isaacson and I have talked about this as well. So postoperative course, at about 6 months, she ended up having an advancing Tunnel sign to the mid-palm. Now she's actually farther beyond that, past the MP joint crease. Again, her thumb kind of opposition and abduction is still pretty good. So that wasn't involved in this. So fortunately for her, she has some crossover. This is her just a few months out. And the reason I'm showing this view is so you can see that kind of bulge almost with this cushion of fat around this entire reconstruction. Both from a pain standpoint, I think it improves, and also from a vascularity potentially as well. So more of a hypothetical thing, but I think it potentially does help. And again, for her, fortunately, she does have good opposition still. Now, I mentioned in the second case that there is a role for internal neurolysis in select cases, but what I don't think there's a good role for is it in routinely for nerve compression syndromes. And internal neurolysis does potentially damage the nerve, and so you have to have a good reason to do this, and releasing just carpal tunnel, cubital tunnel, in my opinion, is not a reason to do that. And this has been borne out by studies, and many authors have shown over decades that there really is no difference in doing this for just straightforward compression neuropathy, even in redo cases. Now, this is not a carpal tunnel syndrome, but I'm just showing this for just to show that what the downside of doing an internal neurolysis. This is a 38-year-old man who, by surgeon number 1, you can see where this is going, had an in situ decompression many years ago. And basically, they ranged the elbow and it didn't purge or didn't sublux, so they left it. A few years go by, 6 months go by. He had recurrent symptoms, but he let it go for a few years, went to surgeon number 2. They did a redo cubital tunnel and did a subcutaneous transposition. But even though they did a sub-Q transposition, they actually didn't fixate it in any way. So the thing was subluxing back and forth, causing a lot of pain. So he has some new symptoms, some persistent symptoms, went to surgeon number 3, 2016. Surgeon number 3 then did a lot of things, including an internal neuroplasty of unusual difficulty. And so at this point, he had some interval resolution of symptoms. However, he ended up having a lot more severe pain eventually. And the pain was a lot worse than before. So the surgeon went back, same surgeon in 2017, did a redo cubital tunnel with a microneuroplasty per the op note. And in this case, you can see the closure was performed and then the tourniquet was deflated. Also for me, especially the more things you do, I think you should just release the tourniquet and make sure everything's hemostatic before you do that. And he ended up getting worse after this even. Had excruciating pain post-op, had no ulnar nerve function for 2 or 3 months, and this was him about a week later. So massive hematoma, a lot of bleeding, obviously, as you can see here. Does not have a bleeding diathesis. And also, if you look at that incision, it's fairly short for having had 3 operations, in my opinion. Every additional operation requires a longer incision, generally speaking. So now here we are. He's got excruciating pain. He's got, eventually his motor function returned, and most of his sensory function except for the dorsal branch. He had incredibly severe pinpoint pain right distal to the medial epicondyle. So the question is, what's this from? Was it the ulnar nerve itself? Was it the MABC? But again, because this is a internal neurolysis thing, you know where this is going. He had good distal function, so the idea here was to cushion the nerve as best we could, but not mess with the nerve anymore because he had good distal function. This was a pain operation. So this is where the pain is. We can see I've marked that kind of starburst pattern. And so we open this up. I'm just going to fly through this real quick. You can see the incision is also fairly anterior. For initially, when you do your releases, at least I usually go between the medial epicondyle, kind of directly over where the money is. And so a lot of scar tissue. Here's a motor branch that we found. Let me just forward. Sorry, my computer's stuck. There we go. We actually found that the intermuscular septum was not released, so we excised a nice chunk of that just to decompress any potential compression sites proximally. Distally, there's a lot of scar tissue at the FCU head, and we decided to do a nice submuscular transposition. Obviously, going through the details here, but mobilize it sufficiently to be able to get it under the muscle. Post-op, he did actually fairly well for a while, but nothing ruins the results like long-term follow-up. And so his pain over where he had pain initially was completely gone. So he didn't have pain over here, distal to the epicondyle, where his neuroma was initially, his neural continuity. But now he had severe pain proximal to the elbow, presumably from additional scarring. So we went back, again, a lot of scarring here. And in this case, I did what I showed in the third case, but only a kind of a more aggressive approach. We ended up doing an adipofascial free flap for cushioning of this thing. It was his 5th or 6th operation. I said, this is the last thing we're going to be doing. So we peeled off the scar off the ulnar nerve. This is proximal to the elbow, so the submuscular part actually worked fairly well. This is our endoside anastomosis to the brachial and then to the brachial vein. And this is a nice adipofascial free flap wrapped around the ulnar nerve and basically closed up. So all this, in my opinion, was kind of a cascade effect from an internal neurolysis that was done that caused all this scar tissue, severe pain, neuromas, and continuity. This was a bit over a year ago, and just a few weeks ago, he unsolicited texted me this and said, actually, his pain's a lot better, and then he's moving his arm freely. And this is about a year out, so I'm hopeful that this is it for him, because I don't want to go back. So take home message for this, I think, this is all about anatomy and landmarks. You need to know where you are. You need to know where the danger zones are. And if you're doing an endo-CTR, just be really vigilant and don't be afraid to convert to open if there's any problems. No one's going to blame you for doing that. If it's a redo, generally speaking, I prefer open. You can see the nerve. Or if it's a very severe primary, you can argue for the same thing. And again, every subsequent release, you need a better exposure for that. And again, don't do an internal neurolysis for a nerve compression. You have to have a really compelling reason to do that, such as the cases that I actually showed. And I think most importantly, everyone has problems, everyone has complications, but you just need to recognize it immediately. So if you recognize it and you address it either intraoperatively or with an early referral or re-exploration, I think that's the key. Well, thank you so much for having me.
Thanks, Bauback. That was great. Next, Jonathan Isaacs is going to talk with us on failed ulnar nerve decompression or cubital tunnel release. And while Jonathan's pulling up his talk, Chuck Cassidy, one of our colleagues in the Hand Education Committee, brought up a great point. If you have a young person that has recurrent, especially bilateral carpal tunnel, early on, think amyloidosis. It's sort of an unusual presentation of something that you can really help them with their overall medical condition in terms of the cardiac symptoms. So that's a great point that Chuck brought up. So Jonathan, thanks.
Thank you, Jeff. Two great talks, hard to follow. Bauback's talks are always hard to follow. I find that my best talks are the ones where I get pictures from him to include. So I want to mention my disclosures as well. We will touch on products that are sold by these companies, but I will be very careful about only providing data from the literature. Let me start by emphasizing a couple of basics. That nerves are metabolically very active, which means that they're hungry for nutrients and oxygen. And the body deals with this, as we know, by providing a rich blood supply to nerves, as well as a cushioning connective tissue layer and mesoneurium, which, if you remember, is the thin tissue around the nerve that allows it to glide through soft tissue planes. Obviously, we wouldn't be having this discussion if this blood supply didn't have some vulnerability both to compression that we've already heard a lot about, and as well as tension, such as when the elbow flexes. And when compression or tension causes ischemia, every now and then, it's not a big deal. And we've all experienced this. Everybody, I think, listening at some point has had their foot fall asleep. And that's an ischemic phenomena, typically to the perineal nerve. And you stomp around the room and it gets better and you're fine and it's not a big deal. But when it happens over and over again, there's actually a reperfusion injury. So in carpal tunnel or cubital tunnel, and this results in increased vascular permeability, leading to edema. And now you have a swollen nerve that's running in a tight space, and the nerve can fall into this kind of downward spiral where the ischemia now leads to fibrosis, subsequently potentially axon loss. And now not only is there bad dysfunction, the dysfunction can potentially be permanent. And I think everybody knows that you can potentially break this cycle early on conservatively, but if not, there's a variety of described surgeries where you release the points of compression. And for the purposes of this discussion, all the stuff you see up on the screen there works about the same and has the same risk of needing revision surgery. I think all of us think about cubital tunnel surgery, similar to as Jeff talked about with carpal tunnel surgery, as predictable and low complication surgeries. But if you go to the literature, unsatisfactory results in up to almost a third of the cases, and failure, outright failure, some reports up to 17%, which to me seems very high, but it is also a little bit sobering. Now, how you're going to approach these patients, how you're going to approach these problems really depends on how you define failure. And Jeff really touched on a lot of these, talking about the carpal tunnel, but basically you're going to break it down into three categories: acutely worse, persistent, and recurrent symptoms. So you got the patient that comes for the first post-op or comes to you shortly after somebody else's post-op, and they just say, I feel much worse. I have more tingling in my ring and little fingers. My hand feels weaker. It's really a lot worse. You have got to consider, as you've already heard, the potential of iatrogenic injury. And that doesn't mean that you have to assume the nerve was cut. And in fact, while ulnar nerve lacerations can occur, it's actually quite rare. But just by manipulating the ulnar nerve, you can elicit a neuropraxic response. And what I would argue probably is the most common thing that we see is the nerve has been transposed, and now you have new iatrogenic kinking or areas of impingement. The patient that presents shortly after surgery and says, okay, my ring and little finger do feel a little bit better, but this thing hurts so much and my elbow's numb and my medial forearm is numb. You have to think about medial antebrachial cutaneous nerve injury. McKinnon and Novak reported that they found MABC neuromas in 70% of their revisions. Others aren't quite so high. That seems like a very high number. And I don't think the take-home message is that in 70% of patients, the MABC gets cut. And certainly not all MABC injuries are that symptomatic, but strong Tunnels, paresthesias, increased pain, all things that would lead you to conclude that there's a chance that that person does have a cutaneous nerve injury. And then we have the patients that are going to come in and now they're at the 3-month follow-up and they say, I just don't feel better. My fingers are still tingling. I still have all of this weakness. And for those patients, the first thing you have to think about is that if the person had severe cubital tunnel syndrome, i.e. that there is some level of ulnar nerve damage, that they may just not have given it enough time. These can take months or even years in some series for the patient to really see improvement. And in some patients, we know that the nerve is so badly damaged that they are not going to recover no matter how long you wait. But that also means it doesn't matter how many times you go in and redo the neurolysis, they're still not going to recover, and you have to keep that in mind. I'm sure there are some cases where not everything was released. I think Bauback gave a great example of that with a anterior transposition and failure to excise the intermuscular septum. That's kind of a classic test question, but certainly something that people still miss. I think it's hard to determine that this has occurred. Again, McKinnon and Novak point out that most common incomplete release is the fascial septum between the FCU and the pronator teres. And that may be true, but I think that's also the point where you're more likely to have iatrogenic kinking or impingement when the nerve has been transposed, particularly through too small of an incision. You need to think about misdiagnoses, double crush phenomenon, remember thoracic galley radiculopathy, though in those disorders, all of the intrinsics are affected and not just the ulnar intrinsics. If the patient's a smoker, think about the Pankos tumor that can affect the lower brachial plexus. I think everybody knows to consider ulnar tunnel syndrome. And then there's the systemic disorders, hypothyroid, diabetes, peripheral neuropathy. I threw up there fibromyalgia. Now, obviously, fibromyalgia doesn't give you intrinsic atrophy and weakness, but if you have a patient whose subjective complaints are outweighing their objective complaints, you felt like they had a thorough and technically well done release, and they just say, I still have tingling, I still have discomfort, you ought to think about this as a potential diagnosis. And then the third category is the recurrent cubital tunnel. So these are the patients that are better for 3 to 6 months and then come back, or, Bauback's example, they can come up back later than that, but this is kind of the classic time frame, 3 to 6 months later, and they come back and they say, I was doing pretty good, and I just think it's coming back. Incomplete release, as we mentioned, is a possibility. Persistent subluxation may be a possibility. I think that is difficult to always determine. And the most common etiology, I'm sure, is scarring and perineural fibrosis around the nerve. As I mentioned, the subluxation to me is a tough one. Plenty of people sublux and don't have any symptoms. I think the ones that this is the problem are pretty obvious. You can almost feel the nerve popping back and forth. And with every twang, they say they feel a shooting pain into their ring and little fingers. So the people that subluxation is the problem, I don't think it's subtle. And I think that if you're digging and saying, maybe it's still subluxing and that's why your symptoms haven't resolved, I think that's a very difficult case to prove. So how are we going to figure it out with all these different options? Well, a lot of it is exactly how you would approach a primary cubital tunnel. The time course, the physical exam, do they have a sharp tunnels over the medial brachicutaneous nerve, or are the symptoms over the ulnar nerve? EMG nerve conduction study, I agree with what already has been said, that in trying to figure out a revision, this is very important. It's actually one of the reasons why I always get a nerve study before my primaries, because if they fail, it's really nice to have a nerve study to compare with afterwards. Now, a couple things to remember, though, is that if they had really bad cubital tunnel syndrome, the nerve study may never go back to normal, even if they have technically have a well-done release, and it still may take a while. But if the nerve study is worse, I think that's very meaningful. MRI ultrasound, as Jeff pointed out, can be very helpful. You can see kinking, you can see nerve enlargement. Again, I'm not sure that an enlarged nerve, even if it's technically fully released, I don't know that the caliber returns to perfectly normal. There is some literature on that, but not enough. But certainly if the nerve looks terrible or if you see kinking, I think that would really point towards the possibility that there is something further that can be done or should be done. So what we're going to do for the patient, obviously it's going to depend on what we think is going on. If it's scar pain, if it's a medial brachicutaneous neuroma, desensitization, neuron type drugs, all very reasonable. For that group that just hasn't gotten better yet, don't be in a hurry to go re-explore them. Give them some time. But then there are going to be the patients that look like that they have gotten worse, look like they have recurrent symptoms that I think are reasonable candidates for revision surgery. And then the last thing I'm going to mention is supercharging, and can that fit into our algorithm? I'll talk about that in just a minute. So if you're going to do the revision surgery, as Bauback talked about, you're going to have a bigger exposure. You typically go above and below, find normal tissue, and work your way to your center. You have to relieve ongoing compression and scarring, so you have to do a thorough neurolysis, excising potential areas of impingement. And the big part of this is you have to prevent recurrence. And there's several different ways you could do that. You can put the nerve into a new tissue bed. So if their first surgery was an in situ release, I think a transposition is a great idea. You're putting the nerve into a fresh tissue bed. If you can't do that, if they've already been transposed, there's other ways you can do this. You can wrap with tissue. Bauback gave what I would say is kind of an extreme example of bringing in fresh tissue. And there's also multiple scar barrier options. Probably an easier way to bring in a new tissue plane is this adipose fat flap. I guess that's redundant as an adipose flap. I guess I didn't need the second fat in there. But the adipose flap has been described as actually a relatively easy flap to do. Not that Bauback's flap wasn't easy also, but this one, you basically, there's a plane, you can see it between the subdermal fat and the deeper fat. You can see up on the screen how I've separated that out, and now I've wrapped a nerve around in that fat bed. This is a very appealing idea, and you do get a nice tissue envelope around the nerve. There's not any real data on how these end up doing. There are wraps that you could use, both commercial and autograft. The ideal wrap should be well tolerated, obviously block axons and block scar tissue. It should allow diffusion of humoral factors and nutrients, and certainly should allow nerve gliding. There's the couple of more popular ones on the market. There's a submucosal extracellular matrix from a processed porcine small intestine tissue. This has been shown in animal data to revascularize and become incorporated in the mesoneurium. There's a collagen product. There's dermal allograft products. For the at least SIS and the collagen, several basically case series that show you do a revision surgery and you wrap one of these around the nerve. I know these are carpal tunnels and not cubital tunnels, but it's the same principle. And you can get good results. And I accept that. They're not controlled studies. I don't know that either one I would take as one approach is superior to another approach, but certainly you can use these and get good results. I'll give the caveat that these are, at least the two products I just mentioned, from animal sources, and you can get xenographic reactions. Both I've seen this, and there are case reports in the literature. Kind of the hot new wrap out there is an Amnion product, which is the fetal membrane. It's an appealing idea that there's a naturally non-adherent plane between the spongy layer and chorion. If you remember back to your med school days when you knew what the amnion was. Okay, I guess that's kind of cool to think about that allows the nerve to glide. I don't know if that's really works that way or not, but certainly there are or appear to be factors in this material that inhibits fibrosis and downregulates inflammatory response. When applied to a animal nerve repair, it didn't really improve axon regeneration, but the investigators did report less adhesions and scar tissue. And similar to the other products I've shown you, case series showing patients with multiple previous surgeries re-released, this stuff wrapped on the nerve, and the patients felt better and had some positive objective findings. To me, the strongest wrap, the most powerful tool that we have to wrap around the nerve is an autologous vein wrap. And basically, what happens, you wrap this around the nerve, scar attaches to the outside of the vein, but the intimal layer, which is against the surface of the nerve, stays scar-free and maintains this gliding plane. There's some data that says this may even improve epidural vascularity, and similar to the other stuff, a case series. In this case, though, patients had on average over 3 previous surgeries, which is really a more difficult patient population, but with really good outcomes. My experience with this has been very positive overall. I have gone back in on these and seen similar to this published case series, second look surgeries where you can clearly see a scar-free plane between the vein and the underlying nerve. Here's a ulnar nerve that I'm taking the scar off of, saphenous vein. You need 3 to 4 times the length of vein as nerve that you want to wrap, basically. You split the vein longitudinally, like you see up on the screen there, and then you wrap it around like a spiral or a candy cane. Prolines in between the loops will help hold the construct together. And then you suture this not to the nerve, but to the tissue bed, because the whole point is you want the nerve to be able to glide inside this vein wrap construct. The downside is that patients have problems when you make an incision on their leg, like you see up on the screen there. Many of these patients will have persistent swelling in their leg and will cuss you for months. Often they get better, but it's really something you have to think about. So I talk to patients about it and I say, look, we're going to pull out the big guns only if we have to, but you may have to pay a price for it. And that's the price that you just saw up on the screen there. So the last thing I wanted to mention was supercharging. And there are going to be situations where either you are doing a revision cubital tunnel or a patient has had a cubital tunnel and they come to you with persistent atrophy. And the question is, can you make this better? And you don't think that redoing the nerve release is going to make the difference. So conceptually, supercharging is that you're going to take a donor nerve, you put it into the side of the recipient nerve, in this case, the motor branch of the ulnar nerve, and you're going to augment that depleted axonal pool, hoping to get more axons to the end target. It's derived from this surgery here. This surgery was described for ulnar nerve injuries, not cubital tunnel syndrome, but ulnar nerve injuries. And you could see that the anterior neurosseous nerve has been harvested at the pronator quadratus, transferred to the motor component of the ulnar nerve, in this case, in an end-to-end fashion. Now, you're not going to want to do this, I don't believe, in a cubital tunnel syndrome, but McKinnon's group recognized that this anatomy lends itself really nicely to a supercharging type procedure. So you take that AIN, you haven't cut the motor component of the ulnar nerve, but you suture it to an epidural, and I think you make perineural windows also, but you suture it to that window. It makes sense that this could help, certainly from a theoretical standpoint. It is hard to demonstrate, at least in the population that we're talking about, revision cubital tunnel syndrome. Dangler did publish on 42 patients. Half of these were revisions, so kind of fall in the context of this talk, and almost all of them did well. So it's encouraging. I'm not sure that it's rock solid proof, but certainly encouraging. And there's a theoretical reason why you would consider this. The downside is, of course, it adds time. Some people say it only adds 10 minutes. It takes 10 minutes to bring the operating microscope and set it up. So I think it takes closer to an hour. Does create longer scar. No morbidity has been reported in any of the published series, but you're mucking with the motor component of the ulnar nerve pretty aggressively, and certainly the potential for iatrogenic injury is there. The results of revision surgery in general are worse than primary surgery, maybe not quite so bad with recurrent compared to the other situations. In published series, about 80% report subjective improvement, but 50% with persistent symptoms. Davidge in their series reported improved visual analog scale. So this is after revision cubital tunnel of 1.4. That is not a very good number. Out of that group, 14 out of 52 did not improve or actually worsened. So the negative predictors of who's going to do not so good after a revision cubital tunnel: patients who've had multiple surgeries. Transpose versus in situ doesn't really seem to make a difference unless they've had a submuscular transposition. Then they tend to do a little bit worse. And as you'd expect, advanced McGowan grade, denervation changes on EMG, and increased age are all negative prognostic factors. So remember, you really need to identify something to fix. Just because a person didn't get better after a cubital tunnel release does not mean that they need to have a second cubital tunnel release. And every time you go in there, especially if you go in there quickly after the last surgery, you have the potential to generate more fibrosis. The statistical chances of you making them worse or no better is definitely real. And with that, I thank you guys for your attention.
Well, thanks, Jonathan. That was great. Next, we have a talk from Phil Blazer. Now, I invited Phil months and months ago to help out with us, and things changed with his daughter's college graduation. So he graciously recorded his talk for us to see. So as we're going to get going with that, and then there was a question from the audience that we'll deal with. So why don't we go ahead with Phil's talk first? So So while we're getting the audio worked out, so Jonathan, you showed for your ulnar nerve revision surgeries, you showed a sort of a fat flap, sort of a local flap, and then the vein wrap. If you had your choice and the person had an adequate supply of fat in that area, would you do that? I call it sort of like a taco shell or a burrito shell of fat, or are you a vein wrapper?
Well, I will tell you the data is definitely better on the vein wrap. I mean, it's been around longer. The fat flap is kind of trending right now. So I think we have to wait a little bit longer before I could really pass judgment. The particular guy I used it on was because he looked at his legs. You didn't want to take a vein from him, but he had plenty of scarring. I usually go in and say, look, we're gonna look at it. If it's not that bad, I'll do an off the shelf wrap on it. Maybe do a fat flap if it looks like you have good tissue for that. And let's be prepared to take a vein. And I have the patient give me freedom to make my decision intraoperatively.
Okay, sounds good. Mark, are we going to be set with Dr. Blazer's talk?
Could you not hear it?
I couldn't hear it.
All right, let's try it again.
Okay, so while we're getting that up and rolling, a question for the panel from our audience. How do you evaluate for proximal median nerve compression in the setting of a failed carpal tunnel release? Something like pronator versus compression at lacertus. What's your go-to evaluation for that, Bauback?
Yeah, so I think you would have the carpal tunnel kind of symptoms, but you would additionally have symptoms of compression more proximally. So you potentially could have paracutaneous branch involvement. So if they're numb more proximally, then that takeoff obviously is proximal to the carpal tunnel. You would generally have achiness in the proximal forearm. You could have also elicit that with kind of repeated pronosupination as well. So I think the provocative maneuvers are certainly different. And usually at least in my experience, the night symptoms are not as present in pronator syndrome in my experience as they are in carpal tunnel. That's more of a subjective thing, but I think those are kind of some things that are different between those. Okay,
two. So history and physical, and then if you want to do a diagnostic study, are you finding that EMG is helpful, or are you finding that musculoskeletal ultrasound is helpful?
You know, I admittedly I'm not that great at doing ultrasound. I just haven't done a lot of it, and so. I tend to defer to a lot of our electrophysiology experts that we fortunately have near us to do our nerve conduction studies and EMGs. Having said that, I definitely is on my to-do list to try to improve my ultrasound skills.
Okay, sounds good. Thanks. All right, let's see if I'm more optimistic.
Good evening. I'm Philip Blazer.
Excellent.
My charge is to discuss neurologic symptoms and injuries in association with fractures of the distal radius, and I'm the chief of hand surgery at Brigham and Women's in Boston. So our learning objectives for this talk are to understand and manage neurologic complications of distal radius fracture and their treatment. So we'll start with a case. This is DC, 58-year-old right-hand dominant female. I recently treated after a ground level fall. She had reduction and presented to my office in about 10 days with these radiographs documenting the loss of the position of reduction that she had achieved initially. We discussed surgical treatment for her injury, but she actually presented with worsening knee pain. Ultimately, she was diagnosed with a septic arthritis by one of my partners and treated with arthroscopic debridement and IV antibiotics. So I lost track of her for a period of time. She returned to see me at 7 weeks post-injury and 5 weeks post-knee debridement with her entire hand paresthetic and painful.
I knew that would happen.
So there's a recent review on neurologic symptoms after distal radius fracture by Burdecci, looking at almost 40 papers over a similar number of years, including both operative and non-operative treatment of these injuries. And almost 25% in some of the series of these patients had neurologic symptoms. Looking at the whole group of papers, it averaged about 5% of patients with distal radius fracture who had neurologic symptoms. The median nerve and carpal tunnel syndrome were the most commonly involved. But the other things that come out of this review include that which particular nerves were involved depended on the type of treatment, operative, non-operative, and in fact, the type of surgery, such that, for example, the superficial branch of the radial nerve was seen not infrequently with the placement of pins or external fixtures and certain RAF of a dorsal approach, but was almost never seen with volar locked placement. Volar locked plate placement. The group will be familiar with the function of the median nerve at the wrist, but the classification of median nerve dysfunction, I think, is helpful when thinking about these. And many authors have divided these injuries into acute, subacute, and late, and I continue to use a format of this type. And for me, acute is ranging from immediate injury to within the first few weeks. Subacute develops symptoms within the first few weeks, but could be up to a couple or perhaps 3 months, and late is beyond 3 months. Different authors will use different time intervals between acute, subacute, and late, but those are the ones that generally I use. In terms of the acute injuries, it's not terribly surprising that patients with injuries like this develop problems with their median nerve. And I think it is important to spend a minute on what is a median nerve contusion versus acute carpal tunnel syndrome. So the classic median nerve contusion demonstrates symptoms and signs for their median nerve that are immediately upon injury and onset and are non-progressive and in fact may improve with things like reduction. As opposed to an acute carpal tunnel syndrome, an ischemia of the nerve, which classically will develop a short delay, hours or days after injury, and typically will progressive or demonstrate worsening function of that nerve. The literature supports, and I continue to treat acute carpal tunnel syndrome as a surgical emergency. So that's the two classic presentations. However, all of us with any significant experience will realize that there are cases, as the Venn diagram suggests here, where there is some degree of overlap and it can be hard to sort out. For me, determining the surgical emergency, the key part of this is there is progression of the nerve dysfunction, and that is what in these cases that are unclear leads me to treat a patient as a surgical emergency. I am aware, and there are some reports in the literature of doing pressure measurements, such as we do for compartment syndrome for the carpal tunnel. I must admit, this is not typically part of my practice at this point. In terms of decompression, I think one can use 1 or 2 incisions, depending on the surgical technique for management of the fracture. Typically, I will perform surgical treatment of the fracture, even if it's only something such as a closed reduction and provisional pin fixation, because I think one can decompress the median nerve at the wrist much more safely with the anatomy restored more towards normal. As we move into the subacute category, but also in the acute category, it's worth thinking about the role of immobilization. I think all of us as residents know that if a patient develops neurologic dysfunction and has had a reduction or is just maintained in external immobilization, such as a plaster, that modifying the immobilization can certainly improve the neurologic symptoms. But worth spending a moment on the cotton loader position, and this is an image from the 1950s demonstrating that the typical cotton loader position really is only suggested to be in slight ulnar deviation and slight flexion, and it is really extremes of that which have been disparaged because of their propensity to bring on median nerve dysfunction. But I think in the acute and subacute time period, the question really becomes how much of the dysfunction is altered anatomy versus the swelling that is associated with the fracture and its treatment. As we move more towards the less acute time phase from the subacute into the late time period, and again, reminding us that immobilization in the subacute time period can have a role. As we get into the late time, more than 3 months, clearly immobilization is most likely not used at all. We really are reminded that it's really the altered anatomy and no longer the swelling that is implicated here. And one look recently at the altered anatomy suggests that the course of the nerve is really impacted, and it is a risk factor for development of symptoms if the center of the capitate is displaced dorsally relative to this line along the volar aspect of the radial shaft, more than 1 centimeter dorsally. The methodology is such that I don't know that we can hang our hat on the 1 centimeter, but certainly qualitatively, it demonstrates that the altered anatomy, I think, is really particularly guiding here. And another study that strongly makes that same suggestion gets at the treatment of late median nerve dysfunction after distal radius fracture. And that the treatment modalities are similar to idiopathic carpal tunnel syndrome, but the altered anatomy really is the key part of it, suggesting surgical treatment. In fact, Kwasny et al. In 1994, the article which this image is taken from discussed 13 cases of malunion of distal radius fractures, all of whom had EMG positive for carpal tunnel, and they performed osteotomy without carpal tunnel release. Interestingly, in their group, 12 of the 13, their carpal tunnel symptoms resolved, and all of them demonstrated nerve conductions which improved postoperatively. And the one patient who did not get relief of their carpal tunnel syndrome did require carpal tunnel release at 6 weeks postoperatively. I think in the era of volar lock plating, there is controversy as to whether the volar plates themselves contribute to median nerve dysfunction. And my own personal bias is that a well-placed, well-reduced fracture, the hardware on the volar part of the wrist does not contribute, although the literature is very unclear. Part of the reason the literature is unclear is I do think that patients such as this one, who I recently operated on for a volar lock plate that is more prominent volarly than we typically would like, can develop not only flexor tendon dysfunction, but also carpal tunnel syndrome. And we treated him surgically for his FPL rupture as well as his carpal tunnel release, as you might imagine. When it comes to the topic of when and how do we do carpal tunnel release in association with distal radius fracture surgical treatment, our group published a study relatively recently looking at over 1,700 distal radius fractures treated operatively at 2 level 1 trauma centers. And we had almost 11% of them who had simultaneous carpal tunnel release. Retrospectively, we were unable to sort out how many of these were for acute symptoms versus what you might really call prophylactic carpal tunnel release. But despite doing almost 11% of these simultaneously, we had about 1% of them return to the operating room in the acute and subacute period, not even taking account the late period for subsequent carpal tunnel release. Our study and others demonstrated some risk factors for development of carpal tunnel syndrome, and in whom the literature suggests that one should consider simultaneous carpal tunnel release, and those include significant fracture translation, much similar to the displacement of the dorsal head of the capitate, the other paper we talked about, but also indicators of high energy trauma, such as open fractures, AOC type, and other surgery or polytrauma in general. In terms of 2 incisions versus 1 incision, I think this is really dealer's choice. 2 incisions, as outlined here by Pope and hand clinics, is certainly appropriate, but I think it's also worth being aware of the radial-sided single incision technique following the FCR sheath and
Alexa,
dividing
give me a 3-minute countdown.
And roof of the FCR sheath component of the transverse carpal ligament where it attaches to the scaphoid and trapezium. And these images are taken from Gwarthmy et al. In 2010. And this is a very viable technique for a single incision simultaneous distal radius fracture and carpal tunnel release. in terms of direct surgical injury to the median nerve, fortunately, this is actually quite uncommon. The median nerve seems to tolerate traction and manipulation surgically quite well. One exception to this is the palmocutaneous branch of the median nerve, which Chung et al. With the image is highlighted here, following it right next to the FCR tendon. And Jones et al. Demonstrated that they saw over 5% of their patients within the FCR sheath, they identified branches of the palmocutaneous branch of the median nerve. I must admit, in my practice, I don't see it 5% of the time, but certainly it's worth spending a moment at the distal part of the incision and keeping the incision of the FCR sheath on the radial side of the sheath to protect the palmocutaneous branch. In terms of the radial sensory nerve and the lateral brachicutaneous nerve, Dr. McKinnon taught us years ago that 75% of our patients, there is overlap between the distributions of these two nerves. So distinguishing neurologic symptoms between the two is complicated. These problems are most common with the placement of pins and external fixation. But as you can see with this image here, many of these patients have both of these, so it's difficult to know which technique is the culprit. It is worth remembering that the radial sensory nerve penetrates the fascia to go from being a subfascial to a subcutaneous structure right about at the level where the proximal Schantz pins are placed. And so most authors will advocate placing the external fixation pins around the distal radius, and particularly those proximal pins via an open technique. When it gets to management of the radial sensory nerve and the lateral brachicutaneous, we get into the management of neuromas in continuity. And I must admit that for much of my career, I have recommended non-operative management for those. However, one of the potential game changers is the use of nerve allograft to reconstruct these, as you can see in a patient of mine with a radial sensory nerve neuroma here that was treated with resection and nerve allograft replacement. The literature is still out on this, but my early experience with this has been that these patients do get significant pain relief, even if they don't get full recovery of their sensation. So returning to our index case, here she is returning at 4 weeks. I did elect to do a distal radius osteotomy with a radial-sided carpal tunnel release. And at 4 weeks, her painful paresthesia is gone. Diminished sensation is almost gone, and she's restored her digital motion. And I do think this has to do with correction of her anatomy. And you can see that the head of her capitate is now almost collinear with the volar aspect of her radial shaft. And so thank you for your attention.
All right, great. So thank you, Phil, by recording, Bauback and Jonathan for joining us tonight. I'm really happy with the way this turned out. I think the series of great talks and brought up some good points. I do want to remind our audience that this is part of a series on complications and upper limb injuries. And as you see over the next few weeks, a few more talks that may be of interest to you. The live courses that we are now back to on AO have been on hold for a few years. A couple upcoming later this year, again, one in June and one in October. And finally, other webinars. So again, good night, everyone. Thank you for your participation. And thanks again, Phil, Bauback, and Jonathan.
Thanks so much for having us.
Good night.
Thank you very much.
Good night.